everyone. Thank you so much for being here. The very first thing we wanted to say is thank you for taking the time to explore what we think is a really beautiful opportunity. And thank you for the work that you do as therapists, as healers in this profoundly troubled moment in time that we find ourselves in. The therapists are doing some of the most sacred work out there, and we're really excited to be presenting this particular opportunity to you. We can get started with the slides. Okay. So first of all, why are we here today? We're very excited about this particular opportunity. We're going to be talking about the introduction of very low dose ketamine. It can be thought of as microdosing ketamine. We can discuss that a little bit more into your therapeutic practice. And my opinion is it's truly a rare opportunity to find an approach that is not as requiring of heavy investment in terms of training and learning new skills on the part of the therapist, and yet yields this much potential for breakthrough. We are here as Joyous. We are a telehealth company that has been prescribing very low dose ketamine for over 2.5 years now. We've had over 72,000 patients. We'll talk a little bit more about us, but we are not the main topic here. The main topic here is psycholytic ketamine in therapy and how it can benefit you. Wonderful. Oh, that is why we're here. So a little bit of a brief overview of what we'll be talking about. Again, as I said, I'm not going to go too deep into who Joyous is, though it is important to know who we are, where we come from, and what we're hoping to achieve with you as partners. We're going to talk about ketamine itself, a little bit on the dosing, the spectrum of what it means to be psycholytic or microdosed, as opposed to a more psychedelic or dissociative dosing. What does psycholytic approach really mean? What does it mean for therapy? We'll talk a little bit about what we've seen from our patients, what kind of experiences they've reported. We'll talk about the science of psycholytic ketamine, and I'm not going to go too deep on you here, but anything that triggers your interest is very much open, fair game for the Q&A portion of things. More about the meat of what therapists need to know, and then we're going to introduce this collaboration program that we are launching this month, Joyous for Therapists. And then we have two wonderful experts here who've been doing this work, Dr. Tracy Ganji and Claudia Chica, social worker, and they're both doing beautiful work. They're going to be able to answer much more of the clinical piece of things, and I hope you've come with many questions. But actually, before I dive into all of this, we're going to hear straight from a clinical expert here, and Tracy has very graciously offered to give a couple of minutes, just an overview of what she has seen. Yep.
Okay, well, thank you, and welcome everybody. I'm glad that other therapists are getting involved in this. This has been such powerful work that I have seen and experienced. My background, I started out as a school psychologist, went on to become a clinical psychologist, and my training in psychedelics was mostly achieved through the IPI program. It's an 11-month program covering MDMA, psilocybin, and ketamine, which was very resourceful. I had read that book, How to Change Your Mind, by Michael Pollan, which was transformative to me. And a local psychiatrist in my area who I knew asked if there were any therapists that were interested in getting trained and doing this kind of work. And I, immediately put my hand up and said me. And she did some training. And that started my journey with getting to know ketamine as a tool in my therapist toolbox. I started there in 2022 in her office. And it was like seeing years of therapy condensed into just 6 treatments that we would offer to clients, including the prep, the ketamine experience, and the integration process. So after that, I decided I wanted to do some more of this. I became a member of Journey Clinical, And I had my own clients. I would go to their houses and I would sit with them during their journey. Of course, Journey Clinical has their own medical um, practitioners, just like Joyous does. And that was that was a psychedelic dosing with them. They were not naive to ketamine. They had already gone through ketamine with me. So I was doing maintenance with them at their house. I think then at a certain point, I heard from Sharon. She was looking for therapists that did this work. And I onboarded some of my clients to do the psycholytic ketamine, of which I had not yet been privy to how that worked. And I definitely saw that was beneficial to my clients. So along the way, I became a member, I became a patient of Journey Clinical. I got my own prescription and I started to do the psycholytic dosing myself. And what I noticed is that it kept that openness that comes with the psychedelic medicine, um, parts of the default mode network that are responsible for self referential thinking. I noticed some of the negative self talk was much, decreased. And so every so often, I'll do my own psycholytic dosing, and I have found it very beneficial to me. So I was flattered that Sharon asked me to talk a little bit about it just to kind of launch some of this talk today. So thank you, Sharon.
Thank you so much.
Sure.
And we'll look forward to hearing from you more in the Q&A section. Okay, and I was going to move forward. So back to a little bit about who Joyous is. So we were founded in 2022, and we've now treated over 72,000 patients with a very low dose daily protocol of ketamine. When we've surveyed our patients, as well as in the intake that we give all patients, it's an extensive medical and psychiatric intake. Nearly 50% of our patients are already in therapy. And that's one thing that I really want to leave you with is we are here because our patients have asked for this. I'll get a little bit more into what they've told us about therapy and Joyous in a second. To continue a little bit more about what Joyous is, we do a very thorough screening of patients who come in seeking help for their anxiety or their depression. Nearly 30% of patients are found to be not eligible, not a good fit for the treatment, either for medical or psychiatric reasons. And we're currently active in 29 US states. The average length of treatment is 5 months with us. Let's continue on. A little bit about us. In terms of the team, we came together as individuals with expertise in the medical side of things, the psychological side of things, and the technological side of things, which actually turns out to be quite complex in terms of telehealth, medical records, prescriptions, etc. We very deliberately wanted to work with these lower doses, the psycholytic, not the psychedelic. And the reason is psychedelic work is beautiful, can be transformative, but this is a different animal. It's a different offering that is more correct for some patients and that was just not available out there. And as I'll show you in a few slides, the results we're seeing are really quite astounding in how profound they are. So it is, as I said, a daily dose protocol. And I'll talk about how personalized it is in just a moment. We're a public benefits corporation, and for those unfamiliar with what that means, it is a statement of putting mission above profit. One of our main value propositions is to be affordable and accessible. So we are the most affordable offering of ketamine on the market that we've heard of, and we have a financial assistance program that folks can apply to if they're experiencing hardship. Our mission is to enable individuals, families, communities, and humanity to live a joyous life. And the way that we have chosen to sort of implement it, our purpose is to enable patients to take charge of their own mental health. In terms of who our patients are, slightly more female than male, primarily Caucasian or white. These are the distributed age groups, largely middle-aged, but not all. We really run the gamut from 18 to, we've had, I think 86 was the oldest age I've seen. Here's our education levels. The average patient has a university degree. And just at a glance, why do patients come to Joyous? Anxious or depressed are the primary reasons. Many of our patients do report having had trauma as well, but we don't take PTSD as a primary indication. I'm not going to go step by step here, but to give you an overview of what it looks like when a patient comes to us. Again, they're extensively screened. 30% of patients are not found eligible for treatment, but those who are fill out an extensive medical intake and then have a telehealth evaluation with a licensed medical practitioner. Again, that's kind of a final check on whether or not they are good fits for the program. And if they are, the medicine is delivered straight to their home. They receive 30 doses, but they don't start at the full dose. Once they indicate that they're ready to get started, we start them on the lowest possible dose. And that is because we want them to build a relationship of safety with this medicine. The thing we don't want is to give people too high of a dose that feels overwhelming, that feels scary, unfamiliar. So we really start them off very, very gently and only slowly raise the dose if their answers on their daily check-ins indicate that it's a good idea. So these daily check-ins examine symptoms, side effects, sleep, mood, other physiological factors, and in a very personalized and precise way, we end up finding the correct dose for each patient, as well as when during the day it might make most sense for them to take their medicine, and whether or not they should be splitting that dose into several smaller doses throughout the day. So it's a very personalized approach to this medicine. Along with the medicine piece, we do offer online digital therapeutics, and it's a program that we're developing more and more. Because, of course, we aim to be affordable, that means that we don't have therapists working with us as an offering to the patients, because you guys deserve to, of course, be paid. And that's sort of where you come in right now, where this program comes in. Moving forward. Right, so as I already said, personalized dosing, personalized times of day, whether or not to split the dose. The average patient is with us for about 5 months. We have a tapering protocol for discontinuing, even though we have not found that there are withdrawal symptoms in discontinuing the medication, unlike something like SSRI. And we're working on a spacing protocol for discontinuation and maintenance as well. Oh. Okay, interesting. My slides have not updated. There we go. Just to let you know that the dose really is personalized. This protocol really is personalized. Here's the distribution of what doses patients end up as at after about 6 weeks. So it's, it really is not like a one size fits all in any way whatsoever. Maybe I should have yours in my view just so I know what they're seeing. My internet's lagging a little bit. And briefly, Joyous is really effective. So what we see here in the first 2 sets of columns is the percentage of patients who have at least 50% reduction in symptoms. And in the second column here, it's how many people no longer qualify for their initial diagnosis. And that's pretty significant. Nearly 50% of people coming to us, I believe this is about 2 months. Yeah, this is 2 months data, no longer qualify for diagnosis. And that's pretty significant. Clinically significant change was defined as more than an 8-point change with a starting score of 15, more than a 5-point change with a starting score of over 12, something like. Don't worry about it. It's more or less the same as the very, very first set of data there. And here's what the PHQ, which is a depression score, and the GAD, which is an anxiety score, look like. So as you can see, by about week 4, 5, the vast majority of patients no longer meet criteria for diagnosis via these 2 scales, and that is pretty impressive. So why not just the medicine? What we started hearing from our patients is we are already bringing this into our therapy. And we were very interested in learning a little bit more about that. So we ran a survey of a section of our patients. Again, found out nearly half of them are in therapy. And of those who are in therapy, almost 30% are already bringing their doses into their sessions with their therapist. So if we just run a little estimate there, we don't have the exact numbers, but nearly 10,000 patients are already bringing their medicine into therapy. And everyone who responded to this survey either said that this enhanced their therapeutic sessions, or at the very least, did not worsen them. It's neutral or very positive. And that we found to be a very, very interesting and promising marker. And so I'd kind of like to say, we're here to rise and meet the moment. We want therapists to know how to work with this medicine because the patients want to bring it in. And those who bring it in, presumably to therapists who haven't been through IPI, like Tracy and Claudia, are already getting great results. And that suggests to us that with proper training and proper support, we can get even better. So that's why we're here to talk about Joyous for Therapists. What is this program? We take care of the medical side of things. Your patient still comes to us, your client, comes to us as our patient. We screen, we do the intake, we look at their other prescription medications, we look at their medical history, we have our medical provider work with them. Our protocol is personalized to their own needs to find the right dose, the right time of day, the right way to take the medicine. We work with them on side effects. We help them troubleshoot anything else that might be standing in the way of them deriving the benefits that we want. And they're on our regular Joyous Daily protocol. You receive some training from us. We're going to be announcing in the coming week or two a certificate program, a CEU accredited, APA accredited CEU certificate program that will be hopefully out this summer. Summer 2025 is the aim, hopefully August. We'd like a 100-day lead time to announce it. You will receive community support. There's a forum only for licensed providers. Our team is here for you. Our medical and nursing team is here for you. Our internal Joyous team is here for you. We're hoping to develop more and more offerings for community support within that therapist forum. In the future, we aim to provide meaningful reporting and insights about our shared patients. As we start to implement more interesting analysis into our digital therapeutics, into online journaling, we may be able to give you some really new and interesting insights about how your patients are interacting with this medicine, what they're reporting about their internal experience, et cetera. And there's going to be a referrals program as well to help you bring your own clients into work with us and we want to incentivize them to say, yes, this is my therapist, to sign that ROI, to allow us to work collaboratively with you. So there will be like a small coupon to help them come on for the first month as well. Launching this month, and again, primarily driven by what our patients are telling us they're already doing and what they want. There's an unofficial training program available right now. If you want to take a look at that, it's about 2 hours long and hit the ground running. It gives you the basics of the ketamine science, how it works in the brain, how we go about prescribing it, dealing with side effects, as well as we worked with clinicians who are already doing this work to provide information about treatment planning, preparation, integration, what to do in the session, how to deal with challenging events as they occur, et cetera. And as I said, an official certificate program will be announced this month. There is an exclusive forum for verified licensed clinicians, and this is the list of licensure types that we are hoping to be working with. And as I said, full medical support for you, access via SMS service to our medical and nursing teams, myself and the J4T team available here for you. And this is getting redundant, so we can move on to the next one. There we go. Let's talk about the clinical side, which presumably you're all here for. One interesting thing to note is that as a field, we really are entering into greater depth work. When I was in graduate school, it was just CBT 100% of the time. And we really appear to be in a psycho-spiritual revolution right now. There's so much more understanding of the importance of big T and little t trauma in how people develop, how they experience life, how they engage with life on the whole, and the importance of working with these deeper childhood experiences to understand what meaning can be uncovered, what identities formed, and how these aspects color the experience of the individual in a pervasive way. All these newer therapies, not all, ACT, DBT is older, but some of these newer therapies, IFS, somatic experiencing, really have people trying to live from their higher selves as well, right? True nature, self, wise mind, become really recognizable aspects of all these modalities that may not have been there 10 to 15 to 20 years ago. And psycholytic ketamine is a tool for this kind of depth. It is a beautiful partnership between these new methodologies that are becoming more and more wanted, sought out by patients, and the state of mind that the psycholytic experience provides. I'm not going to go through all of this, but essentially the psycholytic approach has been around for a while. It is 60 to 70 years old. It was primarily developed with other medicines like LSD and psilocybin. But essentially, the idea is mind loosening. So whereas psychedelic is mind manifesting, you come to these insights. You're on a journey of discovery. You come to see aspects of yourself that may have been deeply in the subconscious. Mind loosening is a softer approach. Go low and go slow, says one of our main advisors. And the idea is to just become a little bit more porous, a little bit more susceptible, a little bit softer around the hard edges that sometimes can arise in therapy in a way that can be quite overwhelming. Interesting. This slide should have been hidden. Ignore that. Oh, no, that one was okay. In terms of the psychedelic versus psycholytic, actually the one before is good too. Thank you. Sorry. The doses that we're talking about for psychedelic, and we're talking about buccal troches right now because that is the method of administration that Joyous uses. Oh, I wish I had my pack on me. That would have been a good idea. They are little waxy cubes that kind of fit between between gum and cheek. So we're going to do a direct comparison of what the doses here are. We prescribe 10 to 120 milligram. That's what you would call psycholytic. And the experience is mild, spacious, and relaxing. Whereas 150, you're getting to a more dissociative state of things. At 300 plus, it starts to be comparable to what you might get with an IV clinic. And you have a full dissociative state, has been called like a K-hole. You can be completely out of body. And again, these can be really wonderful states, but it's a different animal. It's not for skill building, it's for insight. A psychedelic experience in itself does not last 3 or 4 hours. Probably the peak of the experience is really an hour to an hour and a half, but the entire wave can take quite a while to subside. So when people bring it into their therapy, in ketamine psychedelic therapy, typically they're asked to section off about 4 hours. And oh, CEO just popped in to give us some troches. Thank you. There we go. So this is what it looks like. These little waxy cubes. Yeah, that's nice. All right. Thank you. Okay. Oh, okay. We're gonna make it bigger. Okay, here we go. That's what it looks like. We got these waxy cubes that fit between and it looks like he took half of one today, which some people split their dose, as we said. Anyway, so you section off about 4 hours of your day to do a psychedelic ketamine treatment because there's ceremony involved, there's mindset formation, there's the after effects that may take some time to come back into your normal state of awareness. And so these are not really doses that are conducive to your weekly therapy sessions. Whereas with the psycholytic, the whole experience lasts about 40 to 60 minutes. And I want to make clear to say we recommend not driving for 2 hours. So an hour past the end of session still, which is, of course, its own logistical question. But other than that, if they're doing telehealth, they can go straight back to work should they choose to. People remain fully oriented. They know exactly who they are, what they're talking about, where they are, what the purpose here is. It is just a matter of being able to direct attention with intention to therapeutic matters that may sometimes be too overwhelming. Okay, next. Good enough. Again, I'm not going to go through the entire research body here on psycholytics. It is a developing field of research. There's not nearly as much research on psycholytics as there are on, say, IV ketamine, which is where the initial effects for treatment-resistant depression were first established about 25 years ago. So this is still a growing body of work to which Joyous would really love to contribute, perhaps with your help and your data sharing. But nonetheless, there is a body of work that does support this kind of work, both in terms of individual therapy, in couples therapy, and across different ages. There's a story I like to share. One of my best friends is a psychiatrist who does some of this work, actually, and she went to the MAPS conference, the Multidisciplinary Association for Psychedelic Studies, in 2023, where she said the most attended session was one led by Dick Schwartz and Sonny Strasberg. Dick Schwartz, of course, being the originator of IFS. And it was a couples therapy session on psycholytic ketamine. And what she said was, it was really boring to watch because it was just a regular therapy session. It was just going well. And I think that is kind of like the clincher of what we're offering here. It's a regular therapy session. You're doing exactly what you're already doing. It's just the patients are coming in a mindset that predisposes them to make the best use of this, of whatever approach that you two choose to do together. Let's get the slides back. Nice. Thank you. Okay. There we go. So our proposal to you is this is really a sweet spot for therapists. It's already happening. It's already happening for probably thousands of Joyous patients, and it's happening with zero training on the therapist's part, and the outcomes are already 86% successful and 0% deterioration. Proper training, proper support, proper communication amongst people who are doing this can only enhance these already very positive outcomes. Your toolkit is going to remain your toolkit. Your office or your telehealth space remains your office or your telehealth space. Your session length remains your session length. What changes is your patient, your client. They come in more open, more connected with you, more receptive, and because ketamine is an agent of neuroplasticity, the work you do has the potential to endure longer. We'll get into a little bit more of what all this means for therapy. Some of the things that patients have reported to us, and we'll touch on each one of these: greater insight and new perspectives, improved ability to learn new skills, an easier release of difficult emotions, willingness to address previously avoided issues, and increased openness to their therapist's insight and suggestions. So first, greater insight and new perspectives. It's interesting to think about the cognitive science of what's going on here. Ketamine is a dissociative anesthetic. So in these very low doses, in high doses, it can be full dissociation. You are in a surgical state. You're completely out of body. A little bit lower than that, we get to what we call the K-hole, which is still a profoundly dissociated state. Many people do find like great revelation there, but that's not what we're talking about here. We're talking about the partial dissociation of the psycholytics. And what that feels like is almost feeling bigger than your body. It's like if anyone's done an awareness meditation, there's a real similarity there. There's a sense of being porous, having the ability to feel both inside and outside the body. And this state of partial dissociation allows for disidentification. It is literally psychological distance from patterns of thinking. So the feeling of knowing that usually accompanies the thoughts we have, the ruminative thoughts, the obsessive thoughts that really feel true to us, that feeling of knowing is deconstructed from the thought and the sense of self. And that separation allows for new appraisals to arise, new and healthier appraisals. I have a quote here from a patient: "I see myself almost from the outside, like I'm in third person." And because the state is one of nervous system relaxation, it feels good. Often this kind of anxiety that fuels negative appraisals is removed as well. And that allows for more spaciousness for positive appraisals to arise. So here we say negative sentiments are often stripped from cognition. When we talk about the improved ability to learn new skills, as we already mentioned, it is a neuroplastic agent. It creates new synapses in the brain. New synapses means new connections. Many people like to think of psychedelics, and this is not a psychedelic, it's a psycholytic, but as a North Star model. And what that means is you're getting a glimpse into a different state of existing, of being, of experiencing the world. And here you're getting a glimpse into a better regulation state of your nervous system. And that can provide guidance even when they are no longer on the medicine. What does it feel like to be in that regulated state? They can kind of return to it through intuition. And there's also less of an overwhelming sense when it comes to going there with the topics that typically are too difficult for patients. We now know as a field that so much of our negative emotion comes from uncompleted stress cycles, typically around traumatic events, whether big T or little t trauma. When stress gets unreleased in the body, when we tense up, when we resist, when we don't allow the stress cycle to complete, this leads to negative emotions. And the partial dissociation, because you're still able to access the somatic sensations of the nervous system without feeling like they are in your face, it can allow for some of that release to happen much more spontaneously and much more effectively. And as we said, we don't have Maya here today. She had to drop out last minute, but she gave us a quote, which was, "It almost feels like a blanket of safety. Feels like I'm doing therapy with a blanket of safety." And we had you might have caught this quote a little bit earlier in the reel that we had going. The things I don't usually feel like talking about, it's like, yeah, I can talk about that today. We'll send out this presentation. You'll see it again. And that's really what it feels like for a lot of people. That sense of internal safety allows them to go there with the stuff that they don't typically want to. Yeah. And then increased openness to the therapist's suggestions and insights. So with our pilot program that both Tracy and Claudia were a part of, we did ask the patients to fill out outcome rating scales and session rating scales, and we found consistently higher reported levels of closeness with a therapist. I had a direct quote that I should have added here as well. That was, "I'm already quite close to my therapist, but I feel even closer to her now." I believe that was about Maya. So there's a sense of, again, somatic safety, the receptivity, and it opens patients to new possibilities. How do patients describe the experience? We have 3 quotes here. 1, "It feels like the things that used to bother me just glide off my back." 2, "Your mind and body quiet down and you can actually process thoughts, feelings, and behaviors from a quieter, more objective place." And 3, "The thoughts didn't stop, but they didn't trigger any significant emotional response. And any emotions that I felt were coincided with rationalization," if that makes sense. It's a direct quote. So, forgive it, sick it, as it were. But I think these 3 quotes really, really demonstrate something that our CEO likes to point out, which is that it's not that thoughts and emotions stop, it's that the charge behind them changes quite a bit. And that the way in which we used to be somewhat identified with our negative cognitions really seems to ease significantly for many of these patients. Let's hear directly from patients. Okay, there we go.
"I'm stronger and stronger. I get up and I want to do things for the first time in 7 years. I'm being creative again. I used to be artistic. Now I want to do things. I want to create things. I want to travel. I want to see people. I just wanted to hide like a hermit before. Ketamine is opening up my brain to who I was before, is what I'm seeing."
But I think if, like you said, with educating and encouraging people to try it, and it's one of those things that's not for everyone. Maybe it is, but at least if you are experiencing those, because most of the other stuff, whether it's SSRIs, all the other garbage out there, they don't work. And I've never been a fan of big pharma and their approach to things. So I just feel there's something very special here. From start to finish, I just can't say enough with the check-ins and some of the nurses saying, "Great job, we're excited for you," and the portal and the website with other people going through their journeys. It's such a great platform, to the point where I told I'm the oldest of 6 children, and I told a couple of my family members about it, and my brother's on the program as well, and he told, when we started talking about it, he goes, "I don't know why everyone in the world's not on this. This is just like, you feel better, you're clearer, and it's not a
Okay. I'm going to say, let's stop.
I
know we have
also
more
too was
testimonials.
really scared that maybe
More
I've
testimonials
really
like,
been able.
I think
let's skip
I
the
I
rest of
finally
these
feel
if
like
we have too
What
many. We're
ketamine
happy to
has-
show them during the Q&A if we want. Just talking a bit about the cognitive science of this. I know we already started, but just to summarize, that partial dissociation gives you a psychological distance from your overwhelming emotions. Emotions are negative, unpleasant bodily sensations, especially in your nervous system. They become more manageable when you have space around them. And it also provides a sense of perspective because the sense of self can become decoupled from the cognitions that typically fuel it. This allows for a reduced emotional reactivity while processing emotions. And because there's a sense of safety there, patients are able to go to the places that you would love for them to go safely as a therapist. One thing that I'd like to point out, and this is theoretical, this has not been studied directly, but we're piecing together lots of different forms of evidence here, both in terms of how we now know trauma is actually healed and in terms of animal studies that found ketamine to be active in memory areas. It may well be that ketamine is contributing to what's known as memory reconsolidation. So what we know about trauma is that it is a full brain network activation. You have the traumatic memory, both in terms of the semantic memory, what happened, and the autobiographical memory. You have the verbal thinking that goes around it. You have the beliefs that are not even verbal, they're deeply embedded into the sense of identity. And then you have all the nervous system and emotional sensations and feelings that arise. And what we know about real trauma healing is that people are able to then access those memories without triggering the entire nervous system simulation that was previously triggered, that caused a sense of panic. And they're able to view that memory, that semantic memory, less from an autobiographical perspective and less with a sense of simulating the past and being stuck there, but kind of like as though they were watching a movie. And what that's known as memory reconsolidation. You have taken that memory and stripped it away from all of the negative experience that it used to hold. And there's some evidence that this is exactly what ketamine is doing. In terms of neuroplasticity, again, not going to get into the deep science, but ketamine does increase BDNF, which is a prime neurotropic factor leading to synaptogenesis in the brain. New synapses form, new connections, new ways of being able to view a situation. And there's a critical period that happens for 24 to 48 hours after the dose, in which therapeutic activity, journaling, insight can really take hold in a deeper way. There is a very interesting model called the Rebus model, which stands for Reduced Beliefs Under Psychedelics. REBUP really should be, but what it refers to is that we have these top-down lenses, beliefs through which we see the world. Examples of these would be cognitive distortions. You have someone who views the world with catastrophization. They tend to really interpret the sensory input through the lens of everything is going wrong. And what psychedelics appear to do is shift the balance from that top-down lens to the bottom-up processing, where people can reappraise what's actually happening in reality without being forced to view it through the negative lenses that they've developed over time. And there's definitely some evidence that ketamine works in this same way exactly, shifts the balance of processing to the bottom up, where people become more actually in touch with reality and less likely to use their interpretive lenses to experience life. Okay, moving on to what therapists need to know. So 5 key benefits we've identified here. You get to do some deeper work with your clients, accessible training requirements, we think, low risk of psychiatric or medical emergency here. It fits within the framework of your weekly therapy in your usual office space, and lastly, complements the work that you're already doing. Deeper work with your clients. You're going to break through plateaus, and we'll hear directly from, again, Tracy and Claudia soon, but you're going to be able to break through plateaus with some of the patients who have been stuck for a long time. You're going to be able to work with some of the toughest material that patients have been unwilling to work with a sense of safety. one thing that is worth mentioning is that this is similar to other methods that go deep and drop clients into trance-like states or meditative states, like say EMDR. So many of the same principles apply. You want to be largely selective with which clients or patients you feel are appropriate for this. Patients who don't tend to go into dissociative states, patients who have at least some internal stability and may not be the most likely to fall apart with some deeper material. But it's very analogous to some of these methods in that way. It's a way of going deeper and doing more meaningful work that really reaches down to the roots of people's struggles. So no doubt that this should take considerably less training than psychedelic therapy. And the reason for that is that the risk of psychiatric or medical emergency is quite negligible. Ketamine itself is a profoundly safe medication, I should say. It's actually routinely used in pediatric surgery because it is so safe and does not repress or depress the respiratory system at all. But while it itself is quite safe as a medicine, the risk of destabilizing people in psychedelic therapy does exist. And that's because it's such a profoundly different and an exotic state that some people really can't handle it without a sense of panic and overwhelm, increased heart rate. This is not that. The psycholytic state that, by the way, your patients are already familiar with because they have been working with us, because they did work through our protocol, come to the right dose for themselves, work through any side effects that they've experienced with our medical team. The actual likelihood of coming to a difficult or challenging emergency, we've never seen it. And we're not going to say it's zero because never say never, but it's very, very low. So we do believe there's going to be just a lower threshold for training to do psycholytic work than for psychedelic work. And we are producing an APA-approved CEU certificate program for basic work with psycholytic ketamine, which will be available summer 2025. So my call to action to you is sign up now so that you can be informed first when it's available. We'll send you all the links afterwards as well. As we said, it fits within the framework of your weekly therapy in your usual office space. So with psychedelic work, often therapists need to have a bed for patients to lie in, or to fashion something on the floor for them to lie in, eye shades, music, darkness. None of that's necessary. This is a regular therapy session. Some people choose to, draw like a spirit card or do a little meditation first. That's great. It's not necessary. It can only help. So because these low doses rarely produce negative experiences, and because your patient already knows this medicine, they have a relationship with it, they've worked for a medical team, it just really fits seamlessly into what you're already doing. It does not need to be a big production. Lasts about 40 to 60 minutes, and I've already talked extensively about how the emergency, something wrong with our slide, but the emergency likelihood is actually quite low. The only consideration that we do want to emphasize is we think it's best not to drive for 2 hours after taking the medicine, which generally would mean 1 hour after your session is over. For me, that's meant going to a coffee shop for an hour after my session just to process and journal, or doing it via telehealth, and hopefully your patients can find something, your clients can find something nice for them as well. And as we said, this complements the work you're already doing. There's no requirement to learn new modalities. The work you're doing is already suited to this. It's just going to go a bit deeper because your patient is more receptive. We do recommend integration practices like journaling, like really thinking through, maybe meditating on some of the things that arose or were learned. That's always just a good idea, but it's not necessary strictly. This is also theoretical, but we have, the therapists we've spoken to, what we've observed, the patients we've spoken to have told us that some of the best matched approaches to the psycholytic state are those that either do focus on trauma, because again, you're able to go there, or those who have a bit of a spiritual flavor already, as we said, IFS perhaps, DBT. So we think internal family systems can enhance people's access to their parts. You have that sense of spaciousness. You feel like the big room inside where you can see these different parts more distinctly. It reduces that sense of blending. As I said earlier, it's almost like dropping into self, dropping into an awareness meditation. For EMDR, better tolerance for memory processing and reduced distress, somatic experiencing. So while there is this dissociative piece, there's also enhanced bodily awareness, which comes from the fact that the bodily sensations are no longer overwhelming, so they're not being avoided. It's actually quite remarkable to realize how often we avoid feeling our negative feelings. Probably not to this group, but to people in general, it is quite astounding when they really realize it. In terms of psychodynamic work, because people feel less defended, less resistant in general, there can be a sense of greater insight. In terms of ACT, there's more psychological flexibility. And in terms of transpersonal approaches, because there is kind of a natural sense of spiritual experience that comes along with this medicine, it can be really a good facilitator for transpersonal work and interconnectedness. I have a quote here from a friend and therapist who's been working with us. I've been doing trauma work for over 30 years, and these are the most impactful sessions I have ever had. That's from Sanjay Manchanda. So how do we get started before we hear from Tracy and Claudia? And I've got many questions for them if you don't, but I'm hoping that people will actually ask questions. What you're going to do next, if you're interested, is sign up at care.joyous.team/therapy. And you will receive this to your email as well, so you don't have to jot it down right now if you are not in the place to do that. And what that will give you is first access to our forum, as well as first notification when that CEU training, the certificate program, is up and ready. If you choose to sign a BAA with us and to, well, I guess it's 2 layers here. If you give us your license information, we can verify you and give you access to the exclusive therapist forum. We do want a space only for therapists. And if you sign a BAA with us, which means that we'll become partners, as long as your patient agrees, signs a release of information, we will in the future be able to share data and insights amongst one another so that we can collaborate in the patient care. And now I am super excited to invite up Tracy and Claudia. And I'm happy to answer any questions about anything we talked about as well. But we were thinking you probably had the most questions for the clinicians. So I intend to step back and let other people, oh, there we go. We have some Q&A happening. Great. We have the first one. Do you work with associates under supervision of fully licensed clinicians in a group practice setting? That's a great question, Ryan, that I don't actually think we've considered that. I think what we would do in that case is ask to be connected with the supervisor. And take it from there. But that I'm not close to that possibility at all. I think it's really lovely to get people in early in their careers to understand the power of this work. And then we have, and by the way, if anyone would like to raise their hands, we'd love to bring you up so that we can see your lovely faces as well. So Frank asks, you mentioned that you don't take patients with PTSD as the primary indicator. What are the primary contraindications relating to PTSD? None. It would be nice to have our Chief Medical Officer, Bobby, here to answer that particular question. I think the way that we would have answered that, and we don't turn away people with PTSD. It's just that because we're a telehealth program and we think that PTSD is generally a condition with higher acuity, we would really love to know that people are in therapy when they're diagnosed with PTSD. So we've focused more on anxiety and depression, but we've not been turning away people with PTSD. And our folks, I actually have a slide on this in a different presentation. We presented recently on a veterans program that we're running. Folks with PTSD are seeing the same shape of the curve that you saw earlier with the depression and anxiety. It is working for them as well. Oh, yeah. Okay, here we go. We have a clinical question. Heidi Wynn asks, what's the timing of taking the troche prior to the session? What have you found, Tracy and Claudia?
Do you mean how early before the session does the client take it? I'm guessing that's
what seems like the best, or does it differ?
I think usually like a couple of hours has been or maybe an hour or so before. Yeah.
Yeah, I know for me, it was usually about 15 minutes before
we started the session, that they would actually do the troche.
I just remember clients saying, it takes a while too to sort of dissipate. So, sorry for the noise. That in itself takes a little while. So I think they want to kind of get that part out of the way so that they're sort of present and focused on the session and have the troche sort of have dissolved already by that time.
Makes sense. We do have 3 hand raises. Okay, we'll start with Erin, and we can even bring her up if she'd like. I don't know if she would like to. Okay. Erin,
Okay.
please.
I'm here. Hold on. Can you hear me?
Sure.
Okay. All these little thingies were popping up. Okay. So I'm a therapist and I also use Joyous, and I have been telling clients about Joyous for over a year now. Here's my question, and it's kind of along, it might be too clinical or too medical. In my research, from what I understand about ketamine, is it works on the glutamate system, which we're finding is way more effective than the serotonin system, specifically for depression and bipolar depression. So I have clients who have bipolar, and I really think they would benefit from Joyous, but I've yet to have a bipolar client be approved for it. Is there any information to tell me about that? Because I've just kind of stopped suggesting it to them because I don't want to break their hearts anymore.
Absolutely. We do take bipolar 2, but not bipolar 1. And it was a difficult decision because there is some really good research suggesting that if this is actually a good medicine for people with bipolar 1 disorder. We thought of it as a higher acuity condition that, again, we think it's probably a good solution for them, but telehealth may not be the right avenue.
Okay. Yeah, it's just frustrating because especially for people who are manic mostly and then they swing depressive, like the glutamate side would be so good for the depression, because if you give them serotonin drugs, then they end up swinging way manic again, and it's a whole mess. And
yeah,
so
that's interesting. I mean, I obviously I'm not the chief medical officer. It would be interesting to see whether we would be willing to collaborate closely with a psychiatrist,
or maybe do some research into it. Put that on the schedule for research, because I think it's really important.
Thank you.
Okay.
Okay, there is someone else who had their hands up. Jacqueline, if you are, if you'd like to speak, I'm gonna allow you to talk. I'll ask you to unmute or not. Okay, move on to the next. Okay, so okay, no, we already did that one. What is the cost for both the patients and the therapist? Joyous for Therapists is a free collaboration program for therapists. The patients are currently paying $129 a month. That includes the medical care, the prescription, the medication itself, access to our forum, and to our digital therapeutics. It is a subscription model, so patients should be aware that they will be charged again next month, and we try to make that very clear. And yeah, that's, if any follow-up questions, we're open to it. Is there research of the impact of daily use of ketamine physiologically, since it does impact on organs and addiction? Can you comment? Yes, absolutely. We are in the process right now of publishing our chart review, which looks at over 45,000 patients with, God, how many data points? Donna is our head researcher here, 2 million data points, 2.5 million data points. The only organ that we've looked at deliberately is the bladder, because that's the most common one brought to a place of concern, and we have not seen a single case that has merited concern. With some cases, based on the symptomology they have reported, we've asked for follow-up lab screenings, and so far so good. And the way so we're publishing this. I don't have a mechanistic explanation of why we're seeing such high rates of bladder issues with ketamine addiction than with lower. My best understanding would be something like, it's very dose dependent. So if you take a whole bottle of Tylenol, you will wreck your liver. But if you take 1 Tylenol a day for 100 days, there may be some effects, but you're definitely not going to wreck your liver. And I think that it's probably fairly similar with the bladder and ketamine. I personally have not read any other organ impact studies about ketamine specifically. Regarding addiction, we do send out follow-up surveys to our patients. We have not seen that dependency or withdrawal are significant problems. It's not zero, but it's below 1 or 2% reporting any sort of struggles of that kind, and none of them have reported severe struggles. Of course, that is a convenient sample of people who've chosen to answer our follow-up surveys, and we are in the process of running clinical trials with an outside institution who would be helping us to look at that in a much more deliberate way. Do we have data of adult patients with ADHD? No. Great question. That sounds like something.
Oh, I'm one of them.
Okay.
You know, I have ADHD and I specialize in ADHD. My clients typically have ADHD, so my psycholytic clients that were part of this the psycholytic. They were my psycholytic clients that I did this with. Yeah. And they did really well on it. It was very helpful to them. And we're doing maintenance with them too.
Beautiful.
Yeah.
And I would just say one thing about the addiction, because the question about addiction, because this comes up a lot of times in the classes that I teach about therapists who are less familiar with this work, and they often ask about that. And you know, I know what it's like from my clients. I know, you know, the details of what the process is for them and stuff. And so, I mean, you really have to be very committed to do this. And it's, you know, it's not like you're popping a pill and you're, you know, tripping out. That's not what this is, you know. And really, if people want to get their hands on ketamine to abuse it in any way, they can get it anywhere. And, you know, this is more of a collaborative model. And I realize that clients aren't necessarily, they don't have to be working with a therapist, but most people are, you know, because they are doing this as an additional tool to really help in their healing, and they're pretty serious about it. And it's not really the avenue I found that anybody who's looking to sort of abuse it in any way goes. It just doesn't really make sense. When you know the process a bit better and what's involved, it really requires a lot from folks, you know, a lot of information, a lot of time, a lot of giving your history, a lot of all that. And I don't think anybody who really is just kind of looking for a fix, you know, uses these routes. It just doesn't really make sense for them.
We do have a
Yeah,
clinical.
same.
Okay. We do have a clinical question here that I have a slight answer to, but then I'd like to pass it to you guys. I'm working with a client who just began their journey with Joyous. Under the influence of the psycholytic state, she has difficulty thinking and expressing herself. Since she's unable to think clearly, we end up oming together. Any thoughts about how we can make the most of our session? My perspective is her dose is too high.
Yeah.
But
What I was thinking.
that shouldn't be happening.
Yeah.
Great. We have a bunch of clinical questions we've written that we wanted your answer to, and I think Donna can. Do you want me to ask them, or do you want me to? Oh, okay. I will ask them. Sounds good. So, who are the best clients to bring into this kind of work?
Most clients, unless there's contraindications, certainly, yeah, bipolar 1, if there's a risk of going into the manic state, that wouldn't be one of the clients I would choose. Typically, I approach my clients that I know are receptive to deeper work, that they're committed to their therapeutic process and have had experience with therapy, and they'd like more tools in their toolbox. I think that to me is the ideal candidate, especially if they've gone through the medical clearance. That's how I see it. It can apply to most people.
Yeah, I think for me, most of my clients are folks who are really struggling with anxiety and depression seem to get the most relief. And then the third category that I think speaks a little bit more to that sort of maybe spiritual nature or self-development is people are really going through a big life transition. They really find that it really helps give them a lot of clarity, a lot of objectivity about what's going on, a broader perspective on it. So for instance, if, I have a client who was kind of going through the end of a marriage and a divorce, and so big life transition like that, or an illness or something like that, I find that the ketamine can be really, really helpful in sort of giving some peace around some of these things that without it seem to be pretty jarring and pretty negative experiences for people. They find a way of making sense of it and uh, feeling a little bit more empowered when they're going through something like that.
Well said.
We have a few technical questions that I can answer briefly and return to the clinical questions. If there's gum recession, can clients put their troches under their tongue? It's better absorbed through the gum, but yeah, they can. Is there a limitation to how long clients can be on the daily dosage? Is it lifetime, like psychiatric meds, or limited? There's some data on this. Both Dr. Lieben, our CMO, has been working with some military sites with this protocol for years, as well as an Australian psychiatrist, Dr. D'Angelo, has been doing this work for years as well. And it seems like people can safely be on this medication long term. But I do think data is somewhat limited, and it would be great to study this more systematically. We are going to keep publishing our data, but I don't know that we can answer that question definitively. If your patients have SSRIs, any negative interactions? Absolutely not. Yeah, and many patients have. That follow-up was, have patients clients been able to reduce their use of traditional medications? Yes. It's a program that we wanted to actually put together to, again, meet the moment and meet what patients are already telling us they're experiencing. It's still coming. It's not quite there yet. Someone else just asked the same question. Is there possible drug interactions with people who are already on prescription cocktails? There are a few medications that we do screen for. I know that Suboxone, Subutex is one of them, methadone. I believe that no major psychiatric medications are contraindications. There are some, and they should be able to just get that from the qualifier screener on our main page. You just click, get started, and within 2 or 3 questions, if you're on a medication that
Oh, there we are.
I'm back. Sorry, of all the people in this room, my internet is the least stable, of course. Yeah, so hopefully you got that question. If you didn't, my apologies. Let me
I
see.
also wanted to add lamotrigine.
Okay. Thank you for letting us know.
Mm.
Alyssa did have a follow-up to the patient who's oming. She likes how her body feels when she's under this dose, but gets disappointed when she does not have this degree of spaciousness when she calls. I see. Okay. So she likes how the body feels, but she's not really able to engage in therapy. What do you guys think?
I might suggest that some deeper work, even maybe with psychedelic doses, and maybe go through that, coming back to the psycholytic after some deeper work. That might just be my suggestion.
You could also encourage her to, to journal after session when she feels like she's a little bit back to herself, so to speak. I always suggest that to my clients, that they journal, and I just say, even if it's just a couple of sentences or a paragraph, just write a little bit down, because I find like it helps when we meet again for integration. We can kind of bring those notes or the journaling sort of into the session, and you can use it as a starting point. So it's okay that she may not be able to articulate things in the moment, but she could certainly make a point or a practice of writing down her thoughts afterwards, and you could encourage her to do that.
Okay. Good. I've been advised, and it is a true point, to add that while, I answer the question about being on this medication for a lifetime, some people need medical support for life. Some people have insulin needs and they need that every single day. But our aim for the general population, our aim for the average patient is that they not be on this forever. We want this to be a period of reset, 5 to 6 months, learn new skills, change mental habits, and move on with life in a better set point. That is our aim as a company. And so thank you for suggesting that I include that as well. A few more questions for Tracy and for Claudia. How have you integrated psycholytic ketamine work with your existing therapeutic approach?
So through the training through IPI, I started to realize that as a cognitive behavioral therapist, I needed some more tools in the toolbox, just out of curiosity, not because it was mandated or anything. And I started to learn about IFS, polyvagal theory, these other modalities, these trauma-based or trauma-informed modalities. And so I know that when I'm doing the psychedelic work, I use integration workbooks with my clients that have some really great writing prompts, going through the remembering process, what was coming up for them, what were the sensations, what were the thoughts that came up. And then as we move through the healing process, as more content comes up, they start to realize that softening, that loosening, and there's more connectedness that they feel with others, more connectedness within themselves, more clarity, more curiosity. Like I mentioned earlier, there's a lowering of the internal critic that we typically have. And so there's this lightheartedness that people have reported back to me as my clients, and even in my own work with the ketamine that I've noticed. So I'm not sure if that answered the question.
Yeah, I think it's a beautiful compliment to, the trauma-informed work I'm already doing, right? It's really just, there's kind of two parts to it. It kind of helps people be more compassionate, I think, to themselves. And I think to me that often is the root, we have to forgive ourselves. And I think ketamine helps with that. I really do. And, if you can have some of that compassion for yourself, it really makes a lot of things possible. It helps with that being stuck part that a lot of my clients say they are. They will say the words to me, I feel stuck. I feel stuck. These are primarily clients who I've worked with for years who are very much engaged in the therapeutic process, who have a sort of intellectual understanding of a lot of their patterns and habits, but haven't been able to change them really, because it's really emotional. That's really what it comes down to, right? It's the emotional part. So the ketamine really helps with that. And then that's when you usually start to see shifts. And at first they may seem very subtle, but they're actually, it's our job to point out how big they really are. How when we see a different way of a client sort of processing something than they normally would have in a session, it's like, wow, that sounds very differently from the way you would have handled that in the past, But anyway, I really do think it just gives you this strength about yourself, this like self-love, really, and I think when you have that, when you're able to connect to what that feels like, where it's not just jargon, that you're reading in a book or somebody's preaching to you, when you actually can feel what that feels like to have compassion and forgiveness for yourself, or self-love, I think that's the game changer.
Beautiful. We have one more technical question, then I'll ask another clinical question. I think that's all we have time for. Someone said, I may have missed this in the presentation. Does the medicine in low doses with the troche just get absorbed, or does the client swallow or spit out the medicine? Are there any side effects with low dose like nausea? Generally, it just gets absorbed into the cheek and the gum. If they swallow their saliva, it's not a problem at all. And in terms of the side effects, we do see some side effects, but they're fairly minimal and typically addressed within a week or two of treatment. And the most common side effects are mild nausea, dizziness. So if it's a little bit of lightheadedness, that is the psycholytic state. But if it's real dizziness, then we work with that. Sleep disruption can be a problem for some patients. For those patients, we typically say take it earlier in the day, and that usually solves the problem. That's that. Let's get back to one last clinical question for our experts. How about, gosh, what kind of breakthroughs have you seen? Let's end on a fun note.
I know for me, I'm sorting through a bunch of different clients. I think overall, the insights are pretty profound, that I know these clients would not have gotten to that level of self-awareness had it not been for the help of the medicine. What we're talking about, that feeling of empathy with themselves, self-empathy, self-compassion is pretty profound of a change in almost all of the clients that I've worked with, whether it be psycholytic or psychedelic. So the insights, the self-compassion, which then lends itself over to compassion for others. There's more flexibility, there's less rigidity. I think it's a quality of life change for sure. Absolutely. Yeah.
Yeah, I think clients feel more able to control and influence things in their life, where before they didn't. Like life was happening to them, and now they feel and are experiencing them. And that's very empowering when you realize, if I can't be triggered, let's say, by this thing that always triggers me, you now are like, it's a very different experience of the world then, so it releases some of that victim mentality stuff that I think maybe all of us have a smidgen of. But it definitely helps with that, and this format specifically makes it a lot more accessible to people. I do work with psychedelic doses, but they're, like you described earlier in the presentation, Sharon, it's a huge commitment, time, taking off of work or not having something the next day, all of that. Some people can do that, and that's wonderful, but a lot of people can't, or they can't afford that. So this allows them, like some of my clients that were in the pilot study for Joyous, one in particular would have never done it, because it would have been too cost prohibitive to her to go the other route. So it really allowed her the exposure to this, which was just absolutely fantastic for her. So just wanted to throw that in there, because we haven't talked, about accessibility. And I know that us in this, this line of work, that's something that's usually very important to us. So.
Right.
I want to thank everyone for being here today, for the beautiful work that you're doing, and for Tracy and Claudia for coming and giving us their wisdom as well. Please go to care.joyous.team/therapy. You'll get it in your emails. Feel free to email us at therapy@joyous.team as well with any follow-up questions. We would love to have you sign up and be part of this program, know about the CEU certificate program when it's available, and we hope to work with you. Thank you.
Thank you, Sharon. Thanks for having us.
Yeah, thank you so much. Bye.
Bye, everyone.